name is Alexandre Marra. I am professor of the postgraduation stricto sensu program in health sciences at Albert Einstein, Instituto Israelita de Ensino e Pesquisa, and I am also a researcher at Hospital Israelita Albert Einstein. I have been researching at the University of Iowa Internal Medicine Department in Iowa City, Iowa for over 10 years. I'm thrilled to introduce our international webinar series featuring guest speakers. This is the second presentation of the year 2025. The International Webinar Series is part of our global initiative within the postgraduate program designed to connect Brazilian researchers, students, and healthcare personnel with international professors and researchers. It's my pleasure to introduce our guest speaker, Dr. Daisuke Sugiyama. Professor Sugiyama is a clinical associate professor of anesthesiology at the University of Iowa Healthcare, specializing in perioperative medicine for major surgeries. His clinical expertise and research are focused on enhancing patient safety and recovery through enhanced recovery after surgery protocols. With training from the Gunma University School of Medicine in Maebashi, Shinshu University of Matsumoto, where he completed his residency, fellowship, and PhD. And at the University of Iowa, Dr. Sugiyama is also a dedicated educator for the next generation of anesthesiologists. I have been honored to have Dr. Sugiyama as a mentor for my son Vinicius at the University of Iowa, and it's been rewarding to see Vinicius collaborate with Dr. Sugiyama on a couple of research projects. Dr. Sugiyama will talk to us about where does postoperative pain come from. We have planned for Dr. Sugiyama to speak for 30-35 minutes, after which you have 15-20 minutes to answer questions. You can unmute yourself and ask questions for after Dr. Sugiyama talk. Or you can type your question in the chat. I'd like to ask for all of you to answer the survey at the end of your presentation. Thank you, and I will now hand it over to Dr. Sugiyama to start. Thank you very much, Dr. Sugiyama. The floor is yours.
Thank you. Thank you for your kind and warm introduction, Dr. Mara. It's a great honor to be able to speak here today. My name is Daisuke Sugiyama, now working at the University of Iowa in the United States. And today I'm going to talk about my work mainly when I studied at the University of Iowa Department of Anesthesia in the Dr. Brennan Laboratory as a postdoc researcher. Today's talk came from kind of basic experiment, but as a MD researcher, I always hope I should do the experiment, which hypotheses and questions came from our clinical experience. And I believe today's talk will be particularly relevant for students and young physicians who are interested in continuing research as MDs or who are considering pursuing research alongside their clinical careers. Initially, when I discussed about the topic, what we should talk today, Dr. Mara asked if I could give a talk about ERAS, enhanced recovery after surgery. However, since an important part of ERAS is reducing opioid use during surgery and creating conditions that minimize postoperative pain, I decided to focus today on the mechanism of postoperative pain, a topic I've been studying for many years. So to understand how we can reduce pain after surgery, we first need to understand where postoperative pain actually comes from. First, since my background is a little bit tricky, and I'd like to briefly introduce myself a little bit. I received my MD in Japan and later obtained my PhD there as well. And from 2014 to 2019, I spent 5 years at the University of Iowa as postdoctoral researcher in Dr. Brennan Laboratory, which developed a well-known experimental model of postoperative pain. And after that, I returned to Japan and worked as a clinical anesthesiologist while continuing my clinical research in 2025, last year, I was fortunate to be recruited back to the University of Iowa, this time as a clinician. Currently, I worked as a clinical anesthesiologist in the Department of Anesthesia at the University of Iowa, and while continuing my research as an MD PhD. Because of this background, the questions I pursue in research are very much from the perioperative and perspective of clinician. And I strongly value the role of being a participating anesthesiologist. And even though my research activities may be relatively modest, I believe it's important to continue doing research and publishing while working as a clinician. If you scan the QR code, oh, I'm sorry, QR code here, uh, you can access my publication. So please feel free to take a look if you are interested. I'll show the QR code at the end of the presentation as well. Here. I show here some photos from several types of surgery. I think many people who join this meeting is working in the hospital or medical field for the patient. And we usually use the word postoperative pain after the surgery. But what is the postoperative pain? Is it different from other pain mechanisms like inflammatory pain, neuropathic pain, or neuroplastic pain? I believe postoperative pain includes several types of pain in it. As you can see in this slide, it includes inflammatory pain and neuropathic pain, nociceptive pain, nociplastic pain, and other pain mechanisms as well. That is a characteristic of postoperative pain, and many people studied about several types of specific pain mechanisms using inflammatory pain animal model and neuropathic pain animal model. Now, actually, I've been studied about the post-operative pain mechanism using post-operative pain animal model. So we anesthesiologists usually do the several types of nerve block for the patient who has the surgery. Why do we use those or these nerve blocks? Because we'd like to inhibit the signal action potential transmission from the surgery area, especially incision tissues. My talk today is a topic what is the mechanism of pain after surgery and what is the role of the TRPA1 in the pain mechanism. Many of you who are listening today probably already be familiar with this. Nobel Prize Physiology or Medicine 2021 was awarded to the temperature sensitive channel, the TRP channel. I think probably most famous TRP channel is TRPV1, and it's a capsaicin channel. And as you can see in this right side, actually there are a lot of TRP channels. And I've been studying about the role of TRPA1 in the pain mechanism after the surgery. Today, I'm going to talk about the role of the TRPA1 in surgery-induced sensitization in muscle nociceptors from my study. And I'd like to introduce the background of the study a little bit first. Dr. Brennan Laboratory in the Department of Anesthesia has been studied about the postoperative pain mechanism and has been shown that deep muscle injury, deep muscle tissue injury, produced key clinical components of the postoperative pain signal. Dr. Brennan created animal model of postoperative pain with the incision to the animal hinople. You might know this model as a Brennan model. As you can see from these figures, deep muscle tissue incision group showed greater pain behavior, especially in spontaneous guarding pain behavior. In the pain mechanism after incision, deep muscle tissue is having some role. However, the specific receptors and their endogenous ligands that are directly responsible for incision-induced pain are currently unknown. And why we target TRPA1? TRPA1 is one of the TRP family channel, and that highly expressed in pain-sensing neurons of dorsal root ganglions or trigeminal ganglions. TRPA1 is mainly expressed in the small DRG neurons, and most of TRPA1 expressed neuron also express TRPV1. Traditionally, TRPA1 was found as a cold sensitive channels, but gradually cleared that it actually responds to many components like wasabi, cinnamon, and garlics. And then here, ANKDM1 is the initial name of the TRPA1. As you can see in this image, most of the TRPA1 positive DRG neurons also express TRPV1. And the TRPA1 is activated by many components like mustard oil, cinnamons, such as natural substances. And TRPA1 also responds to many endogenous products from oxidative stress and metabolism-derived substances. And one of the reactive oxygen species, H2O2, is also activate TRPA1. I actually used H2O2 and 4-HNE in my experiment. So just remember, these H2O2 and 4-HNA are the kind of intrinsic ligand for the TRPA1. And it's reported that H2O2 quickly appear in the wound site. This is the zebrafish tissue just after cut their body. And just after wounding, H2O2 appeared in the wound site like that. So H2O2 has some role in the wound or injury tissue. Therefore, we thought that TRPA1 has an important role in the pain mechanism after incision in the deep muscle tissue, and thought probably endogenous ligands which increase after incision such as H2O2 or 4-HNE. This is our hypothesis. And then from here, I'll show you some of our recent publication and from my data. We reported that TRPA1 antagonist worked only for spontaneous guarding pain behavior after prana incision. These figures show the result of the effect of the TRPA1 antagonist HC drug on several pain behavior after prana incision. This figure shows that HC drug inhibited guarding pain behavior in dose-dependent manner after incision. However, on mechanical and thermal hyperalgesia, that didn't work. Therefore, TRPA1 is probably relative for the spontaneous pain after incision. And we also reported that reactive oxygen species level were increased in vivo rats after incision. As you can see here, reactive oxygen species were increased skin and inside the muscle at POD0 and POD1 after incision. Interestingly, when we locally injected the cataract, this blue column, locally injected cataract with H2O2, the catalyst which catalyzed H2O2, the increasing of ROS was reduced like that. That suggests that those increased reactive oxygen species probably are including some H2O2 in it. These figures show the result of effects of the incision of skin and muscle on tissue H2O2 levels using ELISA. Endogenous TRPA ligands H2O2 were produced in the both muscle and skin tissues after incision. Yeah, after the POD0, POD1, both muscle tissue and skin tissue, the H2O2 level was increased. This is the result of ELISA for 4-HNE as well. 4-HNE was also produced in the muscle tissue after the incision. In the skin tissue, we couldn't get the differences between non-insides group and the insides group. I'd like to summarize the main points of this section. Reactive oxygen species were increased both inside the skin and inside the muscle after incision. That increased reactive oxygen species after incision probably included H2O2. Tissue levels of TRPA1 ligands, H2O2 and 4-HNE, were greater in the inside of the tissue compared to non-inside tissues on POD0 and POD1. Then we confirmed and showed effects of local injection of H2O2 to the skin and muscle tissue in in vivo rats. Local intramuscular injection of H2O2 evokes long-lasting nociceptive behavior, which included flinching, licking, and lifting the injected leg in various volume and concentration of H2O2. Very interestingly, the nociceptive behavior didn't occur when we injected to H2O2 subcutaneously. This very small SQ means subcutaneous injection. These blue columns show that kind of nociceptive behavior didn't occur when we injected to the skin. Only they show they got the H2O2 into the muscle, deep muscle tissue. And this elicited nociceptive behavior by H2O2 were reduced by co-local injection of TRPA1 antagonist AP18. This result suggests that injection of H2O2 into muscle but not skin caused nociceptive behaviors in rats, and that was blocked by TRPA1 antagonist. Then we conducted the in vivo extracellular spinal dorsal horn neuron recordings to confirm the effect of local injection of H2O2. This A shows the example data of the spinal dorsal horn neuron recordings when H2O2 was injected to subcutaneously, and this is just a vehicle injected, and this is injected into the muscle. And here she shows a trend of the activity of the dorsal horn neuron before and after local injection of the H2O2. Very interestingly, spinal dorsal horn neuron activity was much increased after intramuscular H2O2, and it lasted for an hour. These graphs summarize data. Spinal dorsal horn neuron activities didn't have any differences before injection, but it significantly after H2O2 injection into the muscle compared to the subcutaneous or just a vehicle injection. These results suggest that H2O2 injection into the deep tissue evoked long-lasting action potential firing in spinal dorsal horn neurons. Next, we conducted the calcium imaging. You use the DRG neurons from rats. This is a result of the calcium transients induced by H2O2. Example trace is like that. After these are the calcium transients induced by H2O2, and in the B, H2O2 induces the calcium transients in concentration dependent manner, and those calcium transients induced by H2O2 were prohibited TRPA antagonists, HC drugs, and AP18. And rucenium red is a wide TRP channel broker. And so that means H2O2 evokes calcium transients in the DRG neuron, and it's prohibited by TRP channel broker and TRPA1 antagonist as well. We also confirmed these effects of the H2O2 in calcium imaging using TRP1 knockout mice. TRP1 knockout mice didn't show the spontaneous pain behavior after H2O2 injection into the gastrocnemius muscle. And in the calcium imaging, calcium transients was induced in the wild type mice, but didn't induce in the knockout mice. Next, we conducted the calcium imaging using by another intrinsic TRPA1 ligands for HNE. Same thing, as you can see from these figures, for HNE, it elicits the calcium transients in the DRG neurons, and this calcium transients was prohibited by TRP channel blocker and the TRPA1 antagonist as well. And the same things happen in the knockout mice for HNE. In the wild type mice, calcium transients has been knocked, but this calcium transient didn't happen in the knockout mice, TRPA1 knockout mice. To summarize main points of this section, during calcium imaging, H2O2 and 4-HNE respectively elicited calcium transients. And calcium transients evoked by these H2O2 and 4-HNE were inhibited by TRPA1 antagonists, and no calcium influx was elicited by 4-HNE or H2O2 in TRPA1 knockout mice. And this is the last section. Next, we try to study about the difference of the calcium influx induced by H2O2 and 4-HNE innervating skin versus muscle. We retrogradely label skin and muscle innervating DRG neurons by DI and only recorded from those DI labeled DRG neurons in this experiment. C, D, and G, and H are the percent responded cells for the different concentration of H2O2 and 4-HNE. Muscle innervating, this is a muscle. These are the muscle data. Red columns are muscle and blue columns are skin. Muscle innervating DRGs were greater response for the 1 millimolar H2O2 and E, F, and I and J show the percent increase of the response of amplitude for the different concentration of H2O2 and 4-HNE. As you can see in I and J, muscle innervating DRGs showed greater response amplitude for the 4-HNE. Next, we compare the non-incised skin versus incised skin. Just compare the skin, but which has an incision or not. And as you can see, these figures, skin innervating DRG neurons didn't show differences for H2O2 nor for H&E, both percent responded ratio and response amplitude. However, in the muscle, inside the muscle innervating DRG neuron. These shadowed red columns are inside the muscle tissues. DRG shows greater responded ratio, both H2O2 and 4-HNE, and greater response amplitude for 4-HNE in inside the muscle DRG neurons. Therefore, I can say endogenous TRPA1 agonist H2O2 and 4-HNE were increased in wound tissue, and they elicit greater calcium influx in their neurons, especially in those innervating deep muscle tissue after incision. So from our study, I'd like to say postoperative pain are in part mediated by TRPA1 and its endogenous ligands such as H2O2 or 4-HNE in deep muscle tissue. Regarding where postoperative pain comes from and whether a patient experiences severe pain, we can say that the deeper the surgical incision extends into the tissues, the greater the pain tends to be. We haven't yet reached a single simple answer to the question, where does postoperative pain come from? However, our research suggests that one of the mechanisms involves activation of TRPA1 by endogenous ligands generated after surgical incision into deep tissues. Thank you. That's it.
Thank you very much, Dr. Sugiyama. Wonderful presentation. I didn't know about the activation of TRPA1 that you are
Mm,
studying, and I think that it is. I have a question
yeah.
in the chat, but if someone wants to ask any other questions for Dr. Sugiyama, please be my guest. I believe that your research, given the opioid crisis, your research is
Exactly.
much more
Yes.
relevant than ever.
So not only for the opioid, but also
Okay.
we need more other, channel specific pain reliever we are looking for. And the TRPA1 is one of the channel. It's, the probably one of the, good component for that. I believe so.
Yes, and basically on this pathway of the TRPA1 that you explained to us, Uh, how can we more effectively use non-opioid adjunctive to target specific pain pathways and achieve the true opioid-free or
Right.
opioid-sparing anesthesia?
Right. That's a very important question. Thank you. And actually, now we anesthesiologists, especially nowadays, try to, do more regional block for the patients who have surgery. And in that, we can reduce the use of the amount of the opioid. And actually, the TRPA1 is one of the non-selective cation channels through the, sodium or that kind of cation channel through the channel. So that it's a very similar, of the local, regional components when we use a regional block. So not only oral taking of the medicine, but also there is a possibility to use this type of the drug or components for the regional block or yeah, still it's only the animal thing. Not all we couldn't try for the human body yet at all. But in that way, combine, the world's multimodal analgesia includes a lot of, way and the methods to reduce the using of the opioid. And I believe this TRP target to the TRP channel and the TRP1 channel is one of them, I think.
Okay, great. Uh, I open to the public if you have any questions, please type in the chat or we can allow you to ask questions for Dr. Sugiyama. And regarding the artificial intelligence and machine learning algorithms, that is any research about that, or will we one day be able to predict a patient pain pathway response and tailor therapy accordingly?
Oh, using the AI for the pain relief for the patient after surgery is a very interesting point. I never tried, and I'm not sure someone already tried that way. But it's a good point because we always, have had a time to try to find the good point, a good balance for the patient, how combine the multimodal analgesia. Some patients need a lot of opioid, but some patients no. So how specifically, use those of the components, drugs, medicines is really important. And I think I agree with that opinion that, using artificial intelligence using for that, try to find or how to, I'm not sure how to control that, but it's a good idea, I think.
Great. I see here that you have two students that you are mentoring, Mariana,
Oh,
Mariana
oh,
and
got it.
Vinicius.
Mhm.
Mariana and Vinicius, do you have any questions for Dr. Sugiyama? I have a question before they think about that. Uh, your work bridges your PhD research with clinical anesthesiology, and
Right.
how has your Japanese research background helped you identify specific gaps in
Mm.
postoperative pain science that you are now addressing in the US? My question
Mhm.
is there any cultural difference between Japanese, Americans, Brazilians? You have more or less pain?
Right, I got it. That's a very good career question, I think. And my career is not normal and natural Japanese, MD's pathway, I think. But when I started research is, when I entered my PhD course. And at that time, honestly speaking, I didn't have any interest for the pain actually. And field of the anesthesiology we have a lot of category, anesthesia itself or intensive care or more emergency things. Or and one of that is the pain. And honestly speaking, I didn't like pain clinic so much. But my boss at that time, uh, asked me, do the pain research in a more basic experimental way. And at the same time, I started working as a pain clinician. And I found that, really a lot of patients are struggling from the pain, and especially after surgery. Still, we can use opioid or a lot of blockade, but some of them continuously, struggling of the pain after, 6 months or 1 year has passed after surgery. And my interest to the pain and pain mechanism is gradually getting, big. And luckily, I could get a PhD from that study. And in my PhD course period, I could go to the, one of the big facility to do the conducting the research in Japan. And there, I could collaborate with a lot of researcher, only PhD, or some of them are just MD, PhD researcher, but most of them are PhD. And I run that how it's difficult to conduct a research as a basic scientist. And I'm always thought that I'm a MD, PhD researcher. So I'd like to bridge from the both side, PhD side and MD side, because a lot of PhD researchers conducting the research more specific and very tiny, things from their, thinking. But I'd like to always think about the patient and the clinic so that in that way, my way, what I should do is always do the kind of bridge experiments and study. And after that, contacted to the Dr. Brennan, and I came to the University of Iowa as a postdoc researcher. And at the beginning, the period I could be here was only 2 years, but I changed that because the situation of the University of Iowa and Dr. Brennan laboratory was so nice. I extended to the 5 years until my J1 visa has passed. So I'm a PMD, but I could have a period just focused to the study research. That is good thing for me actually. So after I returned to Japan, I still have, motivation to conduct and continue the research. And luckily, I could also have a lot of people who, collaborate with. In that way, after I came back to Iowa last year, just after I arrived here, I studied and conducting research as well. So I'm very lucky, I think. And my pathway is really, really tricky. But and of course, I'm a Japanese, and Japanese way of doing, especially my generation, is I can't say it's good because when I was a PhD student, I I never slept actually. I working as an anesthesiologist from 6 a.m. to 7 p.m. Then I started, conducting research from 7 p.m. until 2 a.m. or 3 a.m. almost every day, or even to the weekend. And I don't want to do that once more, but that period, make me strong and make my career. So I can say that having a focusing time do something is really important for the everyone. I'm sorry, I'm not sure this is well answering your question. That
Oh,
might it's
yes,
yeah.
totally. And I have another question that part of this you answer.
Hmm.
But before that, Mariana type in the chat, congratulations to you. It was a great presentation.
Hmm.
And no, but that the idea of this international webinar, uh, as you are dedicated educator and you teach residents, and
Right.
you said many times about your PhD
Hmm.
and fellows from diverse backgrounds.
Right.
How does your own international training influence your teaching style?
Hmm.
And do you approach mentorship differently because you understand the challenges, as
Right.
you explained very well, from moving from US to Japan and back
Mhm.
forward, of being a trainee in a new environment?
Right. Honestly, I struggled last year how to fit the system and how to teach the people for the resident or trainee or students actually here. But gradually, I understand it's both the way of doing education is similar between Japan and the United States. And actually, I like doing education for the people. And I sometimes got, awarded, educator in some hospital when I was in Japan. So I try to modify my way of doing after I, started working here. And luckily, recently I got a lot of, good compliment from the, residents or trainee when we collaborated to do the anesthesia or do something, presentation. And now I got kind of, motivation and a good mind, or probably my way of doing education is also good in the United States as well. So everyone usually told me that I'm a very, good educator because I always try to them independently, but at the same time carefully teaching at the same time. So they don't have so much, insecurity or anxiety when I work with me. And at the same time, when they want to do something by themselves, I always try to, try it, and accept if it's not so bad. Okay. And in that way, probably they could get confident by themselves. And that, keeps me good, get a good, evaluation from them as well.
Oh, great. Mariana, do you want to ask any questions? Because I see that you have the microphone here.
Mhm.
Or anyone that you want to ask any questions for Dr. Sugiyama. Uh, any questions? Oh, I think that there is one question here.
From Bini.
From Vini.
Mhm.
Congratulations, great presentation. What reasons lead you to pursue anesthesiology?
That's a yeah, interesting question. About 20 years ago in Japan, we didn't have not so much ER doctor, ER specific doctor in the emergency department. ER in Japan at that time, a lot of doctor came from another department and collaborate working at ER. And I at that time I thought that I wanted to become a doctor controlling the breathing and so more specifically treat the patient's breathing, so that the probably anesthesiology is the best way to get that skills and knowledge. And I started working as a resident of the anesthesia, but so that means I didn't have any interest to the pain at that time. And now actually I'm studying about the delirium. At that time, actually, I didn't have any interest about the delirium as well. But after I started working as an anesthesiologist, I found a lot of, clinical pulse or questions or concerns from my patients. And every time I got those of the questions, I always try to find and I always try to, check someone already tried to find the reasons or cause or, programs using the, PubMed or some papers. And when I found that almost no one tried to find that answer, that is a good point for me to start something. And in that way, I started conducting the pain research and the delirium research as well. So I just chose anesthesiologist way because I wanted to handle the good breathing for the patient. But after that, it's gradually changed and changed. So the probably I can say that the people who are very young only think one or two things at that point, but it's changed a lot after that because life is very long. So So, this session is very good because we can share our experiences, how, changed our, life itself is. So from the through the study or, what we did through my, career. So that is my answer why I chose anesthesiologist. Yeah.
No, I like very much the way that you explained it. And yes, you told us that for the first time you didn't realize to study pain, or
Hmm.
that you are studying now, and now you are studying, and
Right.
you mentioned about delirium.
Hmm.
And can you talk to us how do you add to your repository of research topics delirium?
Hmm. Because, the anesthesiologists always, observe the patients very carefully, not only during surgery, but also after surgery as well. And honestly speaking, a lot of patients having a kind of, bad period just after the surgery in PACU or floor. It's because of the delirium. And not only patients, but also our coworker, especially nurse, is struggling how to handle that situation for the patient. And at the same time, when I checked what's the bad effects of the delirium for the patient, actually delirium is shrink our lives after the surgery. The patient life lengths. So at that time, until then, I just thought that delirium is just a bad situation and bad condition just after the surgery period. But actually, that was affected to the patient's life itself. Then I started thinking we should handle this problem and we should solve this problem. That is my entrance of my study about delirium. And delirium and pain is, related to each other a lot. So that it's easy for me to start conducting the delirium research as well.
No, great. I totally agree.
Mhm.
Yes, it makes sense. And I like that for the students or for us in Brazil
Mhm.
to understand the interactions that you are doing in your research. For example, uh, you are working not only with other anesthesiologists, but
Mhm.
you are working with different specialties like Dr.
Right.
Shinozaki.
Right.
This is a psychiatrist.
Yes. Actually, I can say I'm very lucky about that because Dr. Shinozaki, my collaborator of the renal research, was started working University of Iowa, and we could collaborate with each other between the internationally between Iowa and Japan when I was in Japan. And that, our research makes strong more because it's an international study program. And we could get a lot of data from a lot of races of the people, the Asian, not only, Caucasian American people, but also Asian people as well. So, and very lucky I could came back from, came back to Iowa from Japan now. And we still collaborating each other. And so this is a very, lack for me. I couldn't handle that by myself, but only, I can say I was very lucky people. Yeah.
Great. And my last question
Hmm.
before I give you the opportunity for final thoughts, for the international fellows
Hmm.
attending this webinar,
Hmm.
what specific competencies like clinical research or communication should they focus on developing to become valuable contributions to a department like yours
Hmm.
at the University of Iowa?
Right. Now I'm feeling that, as you already realized that my English is not so good, but I can survive here for a year. And just because I, accomplished a lot of things from my research. So my CV has, several types of the publishing paper already. And what I did in my life until today is, make my CV strong. And otherwise, probably it's impossible, to have this opportunity, this started working as a clinician in the United States. So this is very tricky because I never had an examination USMLE, so I don't have any American doctor's license here. I only got Iowa special doctor's license, and I can work here with that. So and for me, Iowa is the most best place to conduct research. So I'm not so interested in, working other place in the United States because I had experience living here for 5 years and I know Iowa a lot. So it's that point is a little bit different from other people probably. I wanted to come to the Iowa, not the United States. So that Iowa is a good place to conduct a lot of things because it's a kind of rural area. And so I just focus to my work and study and not so many, amusement place here, but it's good to focus to our career. And as an international people here, especially Midwest with the United States is good because people are really kind and the way of speaking English is very easy to understand for me as well. So I'm not sure if I went to the East Coast or West Coast of the United States, I I couldn't survive it there, but here Midwest is a good point for me.
Yeah, I totally agree with you. And I asked this because sometimes, we from Brazil, of
Mhm.
course, our language is not English, it's Portuguese. As I told you before the starting this webinar, I'm living
Mhm.
here for more than 10 years, but I'm struggling with, learning English to
Right,
to
exactly.
to to improve my accent day by day.
Hmm.
And I totally agree with you that English cannot be a barrier, for if a student or international student want to work with you in
Right.
Iowa, and and I believe that will be a great collaboration for the future if it's possible. Of
Yeah,
course,
of
that
course.
you need to follow the steps as you mentioned. We
Hmm.
need to find the proper American visa, like J1 to do a
Right.
PhD, for example.
Mhm.
But I'm very thankful for you to accept our invitation. And I mentioned in the beginning of your introduction that I'm also lucky to have you as a mentor of my son,
Hmm.
and I really appreciate that, and I appreciate that you are working together with Vinicius and Mariana as well.
Mhm. Thank you so much. I have to say thank you so much, giving me this opportunity. And I'm very happy to see here with Bini and Mariana and conducting research just after I started working here. It is really nice for me because even though when I wanted to start something here without collaborator or without people, it's very difficult because I didn't get any budget for that. But now I'm already conducted the research with them and try to get some budget for that as well. So in that way, started something is really always very difficult part, but I could start something. So I have to say I really appreciate you and people who collaborated with me.
No, thank you very much.
Mhm.
And to finalize, to wrap up our webinar, usually I give the opportunity for the invited guests to have final thoughts. Do you have any other comments that you want to tell us? Or you are open to receive international
Yeah,
fellows in your lab?
right, right. So, and actually, our Department of University of Iowa, is hiring a lot of Brazilian, anesthesiologists as well. So I have a lot of coworker from Brazil as well. And some of them might be, some of them, I think. And so now, recent registration is really tricky, but until last year, H-1B visa is easy to, get, and that's our ticket to come here. But now it's drastically changed a lot almost every day. So, time is changing very quickly. But if the door is sometimes quickly open and shut down, so accumulate our career and knowledge and publication to prepare for that opportunity. And once if you guys get opportunity and open the door, just grab it. I think it's very important thing. So I when I got request or from the chair of the department, I just immediately after that I just say yes, I want to go there. So and after that it's shut down already. So to prepare always is really important, I think.
Thank you very much, Dr. Sugiyama. It was a pleasure to have you here in our international webinar, and I hope that we can collaborate in the future.
Yes.
And thank you. Thank you.
Thank
I'm
you so
really
much.
grateful. Thank you.
Thank you.
Bye bye. Take care, everyone.
You too. See ya.
See you.